All right. Hi, everyone, and welcome. We are so excited that you're joining us today for our fourth and final session of the Trauma-Informed Outreach and Engagement Learning Community. My name is Jen Elder. I'm the director of the Homeless and Housing Resource Center, and we are so excited to be working with our partners throughout this entire series. Next slide. So as we always start with a quick disclaimer, we are funded by the Substance Abuse and Mental Health Services Administration, but the views and opinions expressed today don't necessarily reflect those of SAMHSA or HHS. Next slide. As with all of our virtual events, we are joined by our American Sign Language interpreters. We also have live captioning. If you're having any technical issues in the webinar today, probably the easiest way to get a hold of our team is to send us a message through the Q&A, and we will do our best to help you troubleshoot. Next slide. So a few webinar instructions, just as a reminder for those who have been joining us, and a welcome if you are new. All the participant lines today are muted and the chat feature is disabled. We are excited to be joined by so many of you, but we encourage you to submit your questions using the Q&A feature. And we're going to get to as many of those during our discussion as we can, but we may not be able to get to all of them. The slides are available now on our website, and we've put the direct link into the chat there for you. And a recording will be available in about a week. After the webinar, at the very end, we'll have a QR code and a link for you to take a very short evaluation to get your certificate of participation. Just a note on that, we have found that sometimes if you go right to that evaluation, it might say that the website is down. That's because everybody is rushing to get there all at once. So if you get that message, just wait maybe 3 or 4 minutes and give it another try. And yeah, with that, next slide. I think this will be all of our great panel today. We're joined again by Jillian and Alicia, who have been marshaling us through this entire learning series, but we're also excited to have some wonderful community presenters to have a robust discussion at the end. So with that, I'm going to hand it over to Jillian to get us started.
Thanks so much, Jen. Hi, everybody. Happy to be here for our fourth and sadly final session of this series. We're really excited, as Jen said, to have multiple panelists and community presenters today. Alicia, my colleague Alicia and I, who both are work for Home-Based, and if you've been on any of the sessions so far, are a little bit hopefully familiar with us as we've been kind of monitoring them as we've gone along. But we're really excited to be here today, especially excited to save most of the time of today's 90-minute webinar for our panel discussion. So as with the last few sessions, if you've attended them, you know we've done some context setting. So we'll still do a bit of that today, but we'll keep it a little more brief so that we have as much time as possible to get to as many questions as we can for our fabulous presenters. So we have our panelists. We have Ashley Blum from Nashville, Tennessee. We have Chad Koyanagi from Oahu, Hawaii, and then we have Liz Fry from Pittsburgh, Pennsylvania. And we'll have them each introduce themselves more fully and share some of the really great experience that they're bringing to this panel today. But really excited to get to them. So we can go to the next slide and we will kick us off. So as a kind of reminder for folks who have been on the sessions, any of the sessions prior, this learning community has been focused on trauma-informed outreach and engagement practices for serving folks who have serious mental illness, serious emotional disturbances, substance use disorders, or co-occurring disorders. And as I said, this is the fourth of our 4-part series. So we've been going through best practices in trauma-informed care and really person-centered outreach, as well as how to connect folks to both services and housing, especially folks who are living unsheltered. And at this point, we can go to the next slide, we're getting to the final bit of that, which is starting to provide behavioral health care in unsheltered encampments. So here we have, especially for folks who have only been able to join, who haven't been able to join or watch previous sessions, or maybe only some of them, just as a reminder to kind of to frame the context of today's final session. We sort of had these sessions build on one another, right? So we talked about trauma-informed care and responding to the trauma of homelessness at first. We've covered lots of really great best practices for doing person-centered outreach for folks living unsheltered. Last session, we talked about how to help make the connection to the homeless response system, both in terms of connecting folks who are experiencing unsheltered homelessness to housing and other resources, and also just as healthcare providers, for those of you who are connecting your providers and your systems of care to the homeless response system as well. And today we wanted to wrap up this session as kind of acknowledging that even when we have folks connected to the homeless response system of care to connect them to housing resources, that there really is still a need that often can take much longer than we would want it to get folks into housing. And so wanting to acknowledge that and talk through ways to actually assess for and provide behavioral health care in unsheltered environments as people are hopefully moving along their way towards housing. Next slide. So before we delve into that main topic today and Alicia and I are gonna provide just a short bit of framing, and before we switch to our panel, we wanted to just give a little bit more of a recap of what we discussed during our first 3 sessions. Again, really encourage folks who weren't able to attend them live to watch the recordings that are available on the site, but just in terms of setting some context and reminders for today. We talked through, over the course of the last 3 sessions, we've talked about and had really great presenters share about how the experience of homelessness is itself traumatic for folks and can also exacerbate effects of other traumatic experiences that people might have in their histories, violence, neglect, abuse, discrimination. We talked about some core concepts in ensuring that you're incorporating trauma-informed care into your work with people experiencing homelessness, and really emphasizing that trauma-informed care is most importantly, rooted in this foundational concept that people and their individual experiences really matter, right? We also covered, and again, with the help of our presenters in previous sessions, explored the roles of outreach and engagement in building trust with people, getting to know their needs and their goals, and really beginning to build a foundation to help connect people to resources that they want and they need. And I've also discussed some different ways to approach and practice really person-centered outreach and engagement. And of course, through all of these, we've emphasized the importance of taking the time and building trust and recognizing that person-centered outreach really not only incorporates principles of trauma-informed care, but also requires compassion and focusing on each individual person's strengths and their needs and their goals for themselves, and really working from a place of humility and partnership. And I know that we'll hear much more about that as we talk with our panelists later today. And then finally, in our most recent session, we talked about the basics of the homeless response systems in different localities and how to connect to your community's local coordinated entry system as part of the homeless response system, both to ensure that people that you're working with who have housing needs are connected to whatever available housing and other supportive resources are available, and also to make sure that your local coordinated entry systems are taking into account to the full extent possible the ways in which behavioral health needs impact people's needs and vulnerabilities. So we can move on to the next slide, thanks. So today, to again build on that, we're gonna talk about how to better understand the potential needs that are associated with serious mental illness, substance use disorder, and serious emotional disturbance for folks who are living in unsheltered environments, encampments or otherwise. Go through the benefits of assessing behavioral health needs and providing care, beginning to provide care to people that are working towards housing but are still unsheltered. And most importantly, identifying some strategies and tools that can be used to assess the needs and actually provide care to folks living in these unsheltered environments. Next slide. So before we provide a little bit of context, if you've been on the sessions before, you're familiar with these 2 polls. We actually have one extra today, but if we could launch that first poll, we're really hoping to get a sense of what would best describe the focus of your work. Is it behavioral health care? Is it physical health care? Is it more homeless services, housing, social services, or outreach? And then we have another option as well. So folks could take a moment to let us know what best describes the focus of your work. We know some folks might do more than one of these, but. And if we can share those results, people keep writing so our panelists have a good sense. Okay, so we've got a good mix of folks who are on the behavioral health care side and homeless services and housing, and then of course scattered about physical health, social service, and outreach, as well as others. So thanks, y'all. Good mix of folks, which is helpful, really helpful for us and our panelists, especially as we're customizing the information that would be most helpful for you. So if we go to the next poll. So this is understanding that some of y'all are working in homelessness, so presumably some of y'all will be on that 100%, but still trying to get a sense of how much you would describe your work is with people who are experiencing homelessness. So we have some options here. If you're 100% dedicated to serving folks experiencing homelessness, if most or some of your clients, or maybe only just a few, again, really helpful for us to frame our content that we're providing, if we have a good sense of who's all on the call today. Thank you. All right, so again, we've got a good mix. So nearly 40% of folks are 100% dedicated, and then the rest of you all are kind of varying degrees of working with clients experiencing homelessness. So appreciate y'all providing that information to us. And then today we have one final poll that we haven't had in the past, since we're actually talking today about beginning to deliver behavioral health services in unsheltered environments. And so it'd be helpful to know if you are a prescriber. So if you're able to prescribe medication, that would be great to know. So if folks could just respond with a yes or no, that would be really helpful too. We can probably share that one. All right, that's really helpful to know. So it seems like only 11 people are prescribers. So for panelists who are trying to kind of customize how detailed you might get in terms of talking about prescribing medications, good to know. Thank you so much, everybody. All right, so we can go on to the next slide. I'm going to just provide a little bit of context about understanding the need, and then I'm going to hand it over to my colleague Alicia to go over a few best practices before we open it up to our panel, and we'll spend most of the time with them. Next slide. So just again, to set the stage here, we wanted to talk about some key barriers to accessing behavioral health care for folks who are living unsheltered. So we have here a few. These are by no means, meant to be a comprehensive list of all the barriers folks are facing in terms of accessing behavioral health, but wanted to focus on a few key things. So, among the highest is, of course, a lack of a safe and stable housing or a safe environment, which can, of course, impact a range of things, right? Including the ability to prioritize, or like the need, to prioritize immediate safety needs, which of course can impact your ability to focus on mental health needs. And also might mean some folks are using substances to stay awake, for example, or possibly to self-medicate. Can really impact the ability to keep track of medication refills. It also means for medications that require refrigeration, for example, there's likely a lack of access to refrigeration for that. And also, of course, difficulty just collecting and maintaining documentation that might be needed to access different kinds of care. There's likely little or no access to mainstream behavioral health care providers for most folks who are living unsheltered, especially what can be really critical, which is on-demand behavioral health care, right? So appointments can be really difficult to make or keep if you're living unsheltered. You most likely don't have great access to transportation to get to, brick and mortar, like traditional providers. And also it can just be difficult to know what the options are in the first place, what resources are available, as well as, for many people, a lack of any kind of consistent phone or internet access to be able to make appointments and research information. It can be, of course, really difficult to identify and diagnose conditions that you might have if you're living unsheltered, both because of the complexities of needs of folks experiencing unsheltered and homelessness, beginning from, needs relating to just basic survival on up, and the lack of access to healthcare providers and others who might be able to help with, understanding or identifying conditions that are relating to mental health and substance use. And then finally, just wanted to highlight the barrier of just the disconnect between the homeless response and health systems, which means that even if someone is connected, for example, to like a traditional street outreach worker or team, that still might not result in ultimately being connected to primary health or behavioral health services, even if the outreach staff that you're connected with has been able to identify particular needs of yours. So again, just wanted to provide a really high level overview of some of the key barriers to that folks who are living unsheltered face when in terms of accessing behavioral health care. We can go to the next slide. So meeting the needs of folks living unsheltered, which we'll obviously hear much more about from our panelists, but just some very basics that can look like a lot of things. This is another list that's not at all intended to be comprehensive, but to meet the needs of folks living unsheltered who have behavioral health needs, right? That can look like providing services and treatments, including medications that are specifically designed to be trauma-informed and to work specifically with the realities of living unsheltered. It can look like interim behavioral health care, which includes harm reduction tactics and overdose prevention while folks are awaiting housing resources. So while they're still living in unsheltered or maybe even sheltered environments. Can look like supporting or helping folks to procure documents that are needed, including ID documents that are required for accessing various resources like insurance and medications and certain other services and treatments. And really critically too, can and hopefully would look like connecting folks to ongoing community-based mental health care or substance use treatment, including peer support. So obviously we'll be focused today on the actual provision of care for folks, but with a goal to, of course, connecting folks to ongoing care as well for anything they might want or need continued assistance with. Next slide. And then, of course, these are, again, really high level just benefits of being able to actually assess and provide behavioral health care in unsheltered environments while people are working towards or awaiting housing resources. So, first and foremost, it allows us to actually provide care to really highly vulnerable people by literally, and figuratively meeting people where they're at. Allows us to reduce barriers like travel and transportation or lack of that, and provide opportunities to really offer options that work best for folks given their specific living environment. And of course, our panelists will talk much more about this in a few moments. Can also help folks prepare for more traditional medical care. So, by providing information to people about what resources are available, which they might want or need, beginning to build and helping folks begin, to build not only an understanding of, but hopefully a trust in the healthcare system, or at least specific providers or types of care. And also just get folks to a place where they're both physically and mentally more ready to potentially seek out and receive more ongoing medical care, both primary and behavioral. And then finally, a benefit of assessing and providing care for folks where they're at in the unsheltered environments allows for better understanding about people's living environments. So both in terms of, like, for example, encampment culture, if folks are staying in encampments, and also just a person's behaviors, which of course can better help you deliver the care that's needed or connect folks to resources that will work specifically for them. So with that, if we go to the next slide, I'm going to hand it over to my colleague, Alicia, who's going to take a few moments to go over some key concepts and evidence-based practices before we open it up to our panelists to share lots of great details. So I will pass it to you, Alicia.
Thank you so much, Jillian. And thank you all for joining us today. We are so excited to be wrapping up this series with you. Thank you for those of us who have joined us for all four, as well as those joining us for this first one today. We're really excited to delve into this with you. And as Jillian mentioned, a really great panel coming up. So I am going to run us through some key concepts and evidence-based practices, and then we will launch into that panel conversation. So at any point, if you have questions that you want to ask of our amazing panel, please feel free to share them in the Q&A panel. Next slide. So when we are conducting unsheltered assessments, some of the key concepts we want to keep in mind first and foremost are safety. So we are meeting people where they are at, and that means prioritizing safety for yourself as an outreach worker, as a prescriber, as a person, a specialist conducting street medicine, as well as the safety of the person and the other people who are residing in the shelter. So when thinking about safety, one thing that we've heard from many street medicine practices as a best practice is having a minimum of 2 staff in the field. That way you can keep an eye on each other and camp activities. So, really just making sure that you're supported out there in the field. Another key way to help ensure safety is to have a safe word that you're able to use if you feel like a situation is escalating and you no longer feel safe in the environment. Another way to help with safety is wearing bright team colors and knowing the encampment layout, the exits, and the culture of the encampment, so that while you're there, you feel safe, you feel like you understand the layout, you feel like you know how to quickly navigate any situation that arises. Another key concept is confidentiality. And we know that when you're working in an unsheltered environment, it can be really hard to guarantee confidentiality, but still so important to all of the work we do. But particularly when we're providing behavioral health care treatment, we're talking through options, we want to make sure the confidentiality is at the forefront of our work. So in order to do that, you want to develop a plan with the person who you're working with. What do they feel comfortable with? And it's really good to give options. There might be options that they haven't thought of that can really help give that confidentiality and that space to talk about how they are feeling about their behavioral health care needs and treatment. Some examples are, we could walk around the corner, we can go to a cafe and talk. If you could have a program car or van, you could provide an option to meet there. You could also meet in a clinic or a program office or another available community space. Once again, you want to make sure that you're working in teams, that you have support during that process. And it's really good to not meet in a person's tent, because that's their house, that's their home, and you want to give them that space, and you also want to give yourself that safety. You also want to make sure you discuss the details of HIPAA while you're working with someone, making sure that they just understand their protections, and try not to talk directly in front of others. You might have to make your introductions, start that initial outreach, but as quickly as possible, trying to really make that a one-on-one conversation with the person you're working with. And then finally, under the key concepts on the left-hand side, we have environment. So really asking the person where they feel most comfortable, especially if you're working in a place with extreme seasons, you might need to find a place where there's sun or shade, and providing an option for standing or sitting. So just being aware of that environment and how to make someone as comfortable as possible, while also acknowledging the realities of providing care in an unsheltered situation. Some street outreach teams that provide behavioral healthcare service bring large umbrellas so that they can meet out there, regardless of when there's sun, there's shade. They can help address things like unexpected rain. And then consider the noise level in the environment. There is a chance that you might not be able to hear the person, and that's okay. Just let them know. Ask them to pause if it gets too loud. You can either try and find a place that's a little quieter, or you can just pause and resume once that noise level calms down. On the right-hand side, you see some practical tips. Being concise. You are meeting someone where they are. You're building that trust. So really, at least when you're starting off, getting that information to them as quickly and effectively as possible. Reviewing consent for anything that you're doing, for the outreach, the treatment, all along the way, making sure that you are getting that consent and providing information, as well as identifying people's goals for your interaction and what you're doing there in the moment with them. So people might have longer term goals that you're working on, but also figuring out what they want to work on today while you're working with them. Helping them gather needed information. And I know that can be a process as well. That's something that, as you're building trust, you'll be able to help with that information process. And of course, do no harm. Next slide. All right, so this is a bit of a refresher from our first session, session 1, but we really wanted to emphasize how important trauma-informed care is when you are meeting people where they are in order to provide behavioral healthcare services. So this might be, you might already know this, but if you don't, trauma-informed care is a strengths-based service delivery approach that is grounded in understanding of and responsiveness to the impacts of trauma. It really emphasizes the physical, psychological, and emotional safety for both providers and survivors, and creates opportunities for survivors to rebuild a sense of control and empowerment. So you can see how important this is when we are out there in the field. We're providing those services to people in unsheltered environments, to people in encampments. We'll make sure that we are following these 4 tenets that are provided here. That includes realizing that people's behavior can be understood in the context of their traumatic experiences, and coping strategies designed to survive adversity and overwhelming circumstances. We also want to recognize the signs and symptoms of trauma in people we are working with. There are trauma screenings and assessments that can assist in the recognition of trauma, as do workforce development, employment assistance, and supervision practices. We want to respond by fully integrating knowledge about trauma into policies and practices. This is incredibly important for whatever policies and procedures you have in place for a street outreach and street medicine program. So making sure that there's an organizational commitment across staff and leadership in terms of how programs, policies, procedures, and practices are designed and implemented. And then finally, actively resisting re-traumatization by taking steps to avoid creating inadvertently stressful or harmful situations or environments. That's why some of the things we talked about on the last slide, maintaining that safe environment, protecting confidentiality, taking your time and building that rapport. So they're also important to helping realize, recognize, respond, and resist trauma. Next, we want to talk about the SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. And it is an evidence-based public health model that you can use in your behavioral healthcare outreach and services to people in unsheltered situations. The key to this model is that the healthcare provider conducts a screening and talks to the person about the levels and severity of their behavioral healthcare need, and then provides a brief intervention that can help enhance motivation, and then provides a referral to treatment. So this is a trauma-informed and harm reduction model to provide, to respond to behavioral health needs, because it's meeting people where they are and providing that brief intervention and opening the doorway for additional treatment options. Next slide. So this slide digs a little deeper into how we can make sure that SBIRT on the street really recognizes that unique environment and the situations that, that you are providing care in. So when screening, you want to ask permission, and you want to use short, validated tools wherever possible. This goes back to that being concise, as well as being trauma-informed and making sure that we're not asking more information than we need at the time. And in terms of providing that brief intervention, making sure that it's person-centered and non-confrontational. So, meeting people where they are and where they want to be with their treatment approach, but offering in a way that improves insight and enhances their motivation. So, really providing that support, as well as that brief light touch that you also then use to provide that referral to treatment. That can look like a lot of different things, and it's going to look different in every community. But you may be able to refer to an emergency room, a detox center, an outpatient care center, or it could just be through ongoing engagement and letting the person that you're engaging with know, when you'll be back around, how they can interact with other people on your team, how they can find you in the clinic. So that referral to treatment is going to look really different depending on what resources your community has available and where the person is at in their recovery journey or in their journey for behavioral healthcare services. Next slide. All right, so this is another review of something that we talked about before, but when you're thinking about techniques for a brief intervention, we really wanted to bring motivational interviewing back into the conversation. You may remember that motivational interviewing is a person-centered way of being with program participants and supporting their journey. It is based on the stages of change and the belief that motivation is fluid and can be positively affected together with trust and conversation. So you can see how this really ties into the SBIRT model and making sure that you're helping to enhance that motivation for both harm reduction and treatment or abstinence. So there's the PACE and OARS framework, which we talked about before, which really, we're not going to go back through all of them, but really it focuses on working collaboratively with the person and acknowledging that they are the experts in their own lives, respecting their autonomy, their potential, their strengths, and their perspectives, keeping their well-being prioritized at all times, and recognizing that they themselves have the resources and skills needed for change. On the right side, you'll see the 5 A's, which really focus on asking for permission to discuss mental illness or substance use, and asking the person's situation, including what the person already knows. So, you're really having a conversation with the person about where they are and where they want to be. You then provide advice in a clear, strong, and personalized manner about their options for behavioral health care, and then assess whether the person is in a place to receive treatment, pursue abstinence, or engage in harm reduction. And there's no judgment in that assessment. So wherever someone is, whether they're willing to receive treatment, whether they are engaging in harm reduction, whether they can pursue abstinence, you are coming and meeting them where they are. You then assist and support the person to change their behaviors and engage in that treatment, the services, whatever they have agreed that they are willing to do depending on their goals and their decisions. And then you arrange for follow-up contact, connections, and appointments to really keep them moving on their goals. Then the last evidence-based best practice model that we're going to talk about is harm reduction. And this has been a thread throughout all of our conversations, but it's again really focusing on it here when we're thinking about behavioral healthcare in the field. So harm reduction focuses on meeting people where they are to help them minimize the risks associated with behaviors that can cause harm, such as substance use. Core to harm reduction is that it is really focused on control and choice and honoring a person's autonomy and defining their own path and timeline to getting their treatment, to making changes in their own life, while still promoting greater health and safety. This all ties in together, because as you're doing that, the hope is that you're going to be able to make positive behavioral changes, no matter how big or small, while you're building that rapport and you're building that trust to keep making those changes and keep moving along their journey. It is critical for street-based care for people with serious mental illnesses and our substance use disorders to really have this harm reduction approach, and to build that into all of the different ways that we're doing our work, from outreach and engagement to providing treatment and referrals. All right, and with that, I am going to hand it back over to my colleague, Jillian, to kick off our panel.
Thanks so much, Alicia, and thanks y'all for sticking with us as we went over some basic concepts, mostly so that we could let Ashley and Chad and Liz get into the actual fun, like nitty-gritty details of sharing with y'all what it's like to actually do this work out in the field. So appreciate you all being with us as we provided some of that context. So I am thrilled to introduce, at least shortly, and then I'll let them each introduce themselves, Ashley Blum, who is the Homeless Outreach Services Director at Park Center in Nashville, Tennessee, Chad Koyanagi, who is a community psychiatrist at the Institute for Human Services Street Medicine team, and also a psychiatric hospitalist at Adventist Castle Hospital on Oahu in Hawaii. And then Liz Fry, who is a street psychiatrist and also the vice chair for the Street Medicine Institute's board of directors. And we're, again, really, really thrilled and grateful that all three of them could join us. I think we're going to drop the slides and just be able to see and hear from our fabulous panelists. And to kick this off, I'm just going to ask each of them, and I'll just ask you each one by one to maybe spend a few minutes introducing yourselves, share a little bit about what your current position and work is, if you would like to provide a little detail on kind of how you came to this work or previous positions that you feel like are similar to what you're doing now or have built to where you are now. And then just this sort of a brief overview of kind of the ways in which you, your organization or agency work with folks who are unsheltered, especially with respect to meeting their behavioral health needs. So I'm going to go alphabetical. I'm going to start with Ashley, if you wouldn't mind going first.
Hey, everybody. Thanks for having me. My name is Ashley Blum, and I'm the director of the Homeless Outreach Program with Park Center here in Nashville, Tennessee. And Park Center is a mental health organization that has been around since 1984, providing mental health care to people that are experiencing mental illness, substance use disorders, homelessness, people that are in need of employment services, housing. And so I have been on the Park Center team for the last 15 years. And so I have spent my time really building a street outreach program that fills gaps in Nashville. There are several things that, as y'all heard before, several things that really limit people's ability to get the care that they need. And so really finding those gaps and figuring out what it is that we need to serve people experiencing homelessness and mental health and substance use disorders has been a passion of mine. So part of that was creating a street medicine program. We've been around doing street medicine for the last 8 years with different entities. And now we partner with a medical clinic here in Nashville that have hired our own psych NP to come out and do psych work with us in the community. So it's just been a really amazing process and way to help meet people where they are. That's one of the biggest barriers to folks not getting the care, is them not having the access to go in for care, or even having fear around getting care. So when we meet them in their comfort zone, it's really a game changer. So that's really what we're doing in Nashville, and I can't wait to be on this panel. Thanks again for having me.
Thanks so much, Ashley. And then again, going in alphabetical order, Chad, I hope if you're there, Chad, do you mind going next? And you're welcome to come off camera if you'd like to. All right, he might have had to step away. Why don't we, Liz, if you don't mind going next, and then hopefully we can circle back around to Chad when he's back.
Sure. Hello, everyone. Nice to meet you. I am Liz Fry. I have spent most of my career doing some sort of work out on the street, providing psychiatric care for people sleeping outside. I have been on the board of the Street Medicine Institute since 2016 and have been leading our annual international symposium since 2017. So here's my plug for our Street Medicine Symposium coming up in September, at the end of September in Toronto, Canada. You can go to streetmedicine.org to check that out. I got my start sort of making things up as I went on the streets of Atlanta when I was in my residency program in psychiatry, starting in 2008. Had the opportunity to start and lead a street medicine team through a federally qualified health center in Atlanta, Georgia, for 5 years. And I am now working at Allegheny Health Network within the Center for Inclusion Health in sort of a multitude of roles. And one of those roles is with the street medicine program there. As far as our services go at Allegheny Health Network, the idea for the Center for Inclusion Health is that we work with some of the sort of most excluded individuals in society and in healthcare. So a variety of kind of the people who we work with are people who are refugees, people who have HIV, sex workers, people incarcerated or recently coming out of incarceration, people sleeping on the streets in Pittsburgh, etc. And oftentimes a lot of our folks are sort of multiply excluded in different ways. And the idea is that we have both the patient in front of us that we're working with, but also the other patient is the health system that doesn't do a great job of taking care of all people. And we see ourselves as treating both that patient, but also that health system, with the idea that we can learn how to provide better care for all people within our community if we have a great understanding of how to provide care for the sort of most excluded individuals in our community. In terms of what our street medicine program offers, I am the psychiatrist. We have 2 part-time internists on our team. We have a nurse practitioner, a nurse navigator, a social worker, and a peer outreach worker, a community health worker. And we do everything kind of from physical health care, mental health care, prescribing, getting people started on buprenorphine on the streets, to providing kind of wound care, coordination of care and connection to all kinds of services indoors, both through our health system and otherwise. And also getting people connected to housing and all of the things that go into that.
Awesome. Thanks so much, Liz. And I think we have Chad back. I see you went off mute. So Chad, if you have are back and able to introduce yourself, that'd be great too.
I am back. How do I get my camera back on?
You should be able to just click on the start video at the bottom in the Zoom.
Okay, go.
Perfect.
Hi.
Thanks.
Hi, great. I'm Chad Koinagi. I live on Oahu, Hawaii. I've been a community psychiatrist for 22 years. Sadly, the state of care for our chronically homeless folks is still figuring out what things work for our patients. Some of the same people that were homeless and on the streets back when I was coming out of residency are still, some of them are still on the streets of Chinatown on Oahu. Some of the laws, I believe, regarding people's right to refuse treatment and some of the responses to the deinstitutionalization of the state hospitals have failed, as we don't have assertive community treatment teams anymore. For whatever reason, our Department of Health got rid of them. So we don't have the best practice as far as intensive case management for the community. We have approximately 4,000 unsheltered individuals on Oahu. I think our homelessness rate is 1 or 2. We compete with Washington, D.C. every year for who has the most percentage of homeless folks. Because my practice, I'm a psychiatrist and I do street medicine, a lot of it is focused on providing care to severely mentally ill individuals, like people with schizophrenia, people with schizoaffective disorder, bipolar disorder. Many of them have overlaying methamphetamine addiction, which is our number one community need, probably contributing to homelessness. And so our agency, which started in the 1970s as a primarily homeless emergency shelter, which has now has had to develop new programs such as transitional housing, case management, vocational rehabilitation. We have a vigorous kind of no wrong door walk-in clinic for homeless folks. And then because of my limited time being able to do street medicine, I have chosen to kind of focus on the individuals who are most in need of help. Those are chronically mentally ill, people without much insight, who kind of fall through the cracks of our system. Same ones that I mentioned being there for the last 25 years. So through having myself working in conjunction with the community outreach workers, we have medical providers who can assist with some of the healthcare needs of our patients. We've had to work closely with police to help some of our folks have better kind of coordination of care. We've had to kind of partner with other agencies to try to help them step up. A lot of the chronically mentally ill homeless population has been assigned to case managers through different agencies through the Medicaid behavioral carve-out system, but many of those agencies have quite a bit to go as far as kind of basic skills regarding providing care to unsheltered homeless folks. So, and we've also been involved with advocacy for some of the laws being changed about assisted community treatment. And I guess the main thing is for this population, you just have to be very persistent. You have to be a strong advocate. Part of the reason why I do inpatient psychiatric work and work at a community hospital is that these folks are somewhat hard to love by people who are not in our field. And a lot of times you just send them to the ER without being with them or advocating why they need to be admitted, because they may not fit the usual criteria of who would be admitted to a psychiatric unit. So if I don't get what I need for my patients, I have to end up admitting to my own hospital where I know I can provide the best care for them.
Thanks, Chad. Creating your own entire continuum of care just among yourself. I appreciate you all taking a few minutes to introduce yourselves and your programs a bit. And we've gotten some questions already from folks, and I just encourage people to keep putting your questions for our panelists in the Q&A box. And we'll get to as many as we can. Before we turn to some of those, I just want to ask again, and we'll start with Liz this time, just to kind of switch it up a bit. If you could just each provide a little bit more detail about the structure of your team or your model. So like the number of people you have, the different roles that you have within your team, whether you have people with lived experience or peer specialists on your team. And then I know you already started to talk through some of the services you provide, but if you want to provide any more kind of general overview details on that, that'd be great too.
Yeah, so like I said, we have now 4 providers. So we have myself as a psychiatrist, We have two folks trained in internal medicine, and one of our nurse navigators recently completed her training and certification and all that for as a family nurse practitioner. So she was working on our team as a nurse navigator, and now she's working on our team as a family nurse practitioner. We have, in anticipation of that person becoming a nurse practitioner, we added another nurse navigator to our team, and she will soon be the only and full-time nurse navigator. We have like I said, a social worker, and I recently found out yesterday she is now an LCSW, so that she surprised us all. She didn't tell any of us about it. And then maybe most importantly, we have a member of our team who is a community health worker, and she has lived experience of homelessness herself, and works a lot with our folks on the street, kind of in some of the practical stuff of getting identification and connection to peer support services and things like that, but also just being both kind of a representative for our team to stay grounded in the reality of the streets and the needs of the people that we're working with in a way that those of us who don't have lived experience that we can't understand in the same way that she can, but also as a huge resource for the people that we're working with who sleep outside, to have somebody there who they can connect with who has that same lived experience. I think hopefully a lot of you know the benefit of having somebody with lived experience on your team, in terms of being able to forge a connection and work towards trust building that I think is maybe the most essential function of what any street medicine team does. So all of the people who can prescribe medicines on our team were all part-time. And then the nurse navigator, social worker, and community health worker are all full-time on our team. And probably are some of the most essential people on our team. As of now, our social worker and sometimes our nurse navigator will do hospital consults. We offer consults certainly to two different hospitals in our health network. One is Allegheny General Hospital, the other is West Penn Hospital. And we offer also some consults, and mostly to the inpatient psychiatric unit at a third hospital, which is Forbes Hospital, in our health network. And then the rest of the work, well, some of the work that we do as a team is also based in our indoor clinic space of the MOUD clinic, medication treatment for opioid use disorder. So we have that people can come to indoors. And then of course, a lot of the services that we provide are out on the streets, doing both sort of street rounds in which we are dropping by different encampments, and also doing street rounds in connection with, we have an outreach team that is staffed by people in our health network who all have extensive experience in street outreach. It's a pilot program through the city of Pittsburgh as an alternative to policing issues related to homelessness. So the idea is essentially that the outreach teams right now it's been in a pilot stage in 3 different police zones in Pittsburgh. The idea is that in responding to 911 calls, our street outreach folks may either co-respond with police or respond instead of police, depending on the hours and the time of the needs of the call. And oftentimes the goal for that is for, if Bob is on the street and sleeps outside most of the time and has some issue in which 911 gets called, that when our outreach team members show up to respond, they already know Bob and all of Bob's needs and can both advocate for Bob and also, like I said, maybe go to address issues that can be addressed better by our outreach workers instead of the police. So they are separate from our street medicine team, but we work very closely in coordination with our outreach folks. I believe this is one of the first examples in the United States of outreach workers working in that capacity from the level of a whole health system. So the pilot has gone well, and we'll be expanding to all 6 police zones in Pittsburgh in the next few months.
Thanks, Liz. Ashley, do you want to go next, chat a bit about the makeup of your team specifically and the roles and some of the services?
Yeah, thanks. So we are opposite of Liz. So we are the street outreach workers we contract with a clinic to do the street medicine portion. We did actually hire our own nurse practitioner, our own psych nurse practitioner. So we will be doing our own street psychiatry, but we still have a partnership with a clinic. And so we are the outreach team to their medical team. So they have, medical doctors, they have nurse practitioners, they have patient navigators, data staff that come out with them when we do street rounds 4 days a week. But my team is the street outreach team kind of that partners with the clinic. And we are made up of 25 staff, including me. And we have SOAR coordinators. For those that aren't familiar with SOAR, it's a fast track disability process to get people disability benefits through Social Security Administration. And so we have 6 SOAR coordinators on our team. We have housing navigators, we have street outreach workers, and we have a data team. And we also have some administrative staff and also a property engagement coordinator to help our housing navigators get people connected to housing quicker. And so what we do essentially is rotate staff to go out with the street medicine team. So we go out and do what we call street rounds 4 days a week. And then we also can make appointments. So whereas someone would go into a clinic for maybe a mental health visit to maybe build records for a disability claim or to support them in their medical needs, we can make appointments with our street medicine team with them on the streets in their encampments and where they live. So that's kind of the model that we use. So doing street rounds where we kind of, rotate encampments that we go to, really trying to expand the camps that we serve so that we're going into all parts of Nashville is really important to us because everyone deserves the care. And if we're just kind of staying in the downtown area, we're just going to be serving the same people. So we're working hard on being more equitable in that way to where we reach into other areas of Nashville. We actually have 10 peers that are actually certified through the state on our team. Maybe it's 9. I think 1 is going through the training right now. But so we also find it very, very important to include people that have lived experience with mental health, substance use, and homelessness on our team. That is a huge part of trust building, and it really does help people see that they can move forward in their journey, and that they're able to do things, like medications, actually being treated in your home is much different than having to go to a clinic. And so it's really important for us on our team to really share their for the peers to share their lived experience, so that they can see that it's okay to take meds. Or we had one staff member who, this story is always an excellent story, because we really worked with this person on all levels. We were able to, one of our peers was working with him, and street medicine was trying to work with him, but he wasn't open to it at the time. But we just kept providing outreach to him. And when our peer explained to him that she took Vivitrol and she took, psychiatric medications, she was able to, he finally was like, oh, wow, I can actually feel better. I can actually get help. I can take a medication that helps me not crave alcohol anymore. And he was sober for 9 months. We were able to get him disability benefits and into housing really quick. And he had experienced homelessness for over 25 years. And so just letting people see that there's a light at the end of their tunnel is really special to us. And it's a really great way for us to be able to work with people in that way, alongside the doctors, because they're there ready to talk with someone once that trust is there. So it's been a work in progress. We've been big and little, and then we've had we worked with a hospital for the first few years, who sent us a psych provider out with residents, and it was a really amazing community partnership. And then once their program ended, we continued with a outpatient clinic in Nashville. So it's been a really great model, and I'm excited to keep it growing with kind of bringing folks onto our team at Park Center.
Thanks, Ashley. And then finally going to Chad, same question about the kind of makeup of your team and the different roles and services.
Okay, so as folks will probably see, talking to different street medicine programs, you'll find a very different story of evolution of how these programs came to be, and the very varying differences as far as funding streams. Our program is probably a few years behind the other two in terms of how long it's been around, and as far as the structure within the program. So we have obviously our street outreach workers, most of which are funded by PATH federal funds for outreach. So we're assigned to different geographical areas of Oahu. And as you can imagine, on Oahu, we have the most varying types of homeless settings. We have people living on beaches, people living on the sidewalks of Chinatown. We have people who just kind of solitary schizophrenic folks who just kind of drift around the island, are very difficult to find, people who live in other encampments. And and there's me, who's a part-time prescriber / provider. And another thing you're going to see is through my years of doing street medicine, I've found it very difficult to, as far as workforce development, training people coming after me to take on this field. I've had various medical students and residents come with me doing outreach for years, and they always seem to find it quite fascinating when they're shadowing you as a faculty member. But when it comes to finding a job, it's very hard to recruit people to this field for whatever reason. I guess you have to find the amazing, compassionate person like Liz, and which is hard to find. And so we also have other providers who primarily work at the clinic, our homeless clinic, but because of our executive director, Connie Mitchell, because the need to provide patient-centered care and to meet them where they're at, it flows throughout our organization. So if there's a patient who we hear about from whatever sources, police, community, who's living in a certain part of the island, which may not have homeless outreach services, Connie will make sure that one of us can go out to that area to engage that individual along with a case outreach worker. And then we have a coordinator who tries to coordinate some of the more seriously impaired folks to my attention, so we can address issues like assisted community treatment petitions for the most severely impaired mentally ill people, or sometimes we have to pursue legal guardianship for folks who have no capacity and are unable to consent to any kind of life-sustaining kind of treatment. So that's our program.
Thanks so much, Chad and all of you, for again, kind of giving that context that we can use for answering additional questions. I'm gonna hand it over to Alicia in a sec to ask the question, but I just wanted to encourage folks to keep putting questions in the chat. I also wanted to just mention specifically, though, we're definitely getting a lot of questions about kind of street outreach generally, which is great, but I also want to encourage folks to specifically take advantage of our great panelists' expertise, and particularly like doing assessments and providing and connecting to behavioral health care as part of outreach. And for folks who have more general outreach questions, if we don't get to them because of our kind of focus today, I would really encourage you to go back and watch session 2 of this series, which is specifically about person-centered outreach and more generally. So if your outreach questions are not getting answered today, I would just encourage you to go back to that session so we can narrow a little bit more today on behavioral health provision. So with that, I will turn it to Alicia to ask the next question of our panelists.
Thank you so much. And I am going to, let's kick it off with Ashley. I'm going to ask the question, what are some best practices in traditional delivery of healthcare that you tweak or change when you're delivering care to people living in unsheltered environments?
Yeah, so when we're providing care to folks that are experiencing unsheltered homelessness, we really have to think about their environment, right? You all spoke about environment earlier, and it's really important for that to be on the forefront of our minds when we're providing care to folks. Like it's raining, it's cold, it's brutally hot, it's, whatever the case is, like homelessness doesn't stop, right? Mental illness doesn't stop. So we don't stop, because like when the pandemic hit, we were out even more because our folks, like things were closed down. And so we needed to be out there more. So I mean, the way that we shift is that we are very member-centered. At Park Center, like we started as a day program at Park Center. So all the people that we serve are members of our program. So that's when I say member, I wanted to give that context. But we're member-centered. We start where they are, and but we have to provide care in that same way. So, you think it's raining out. So like, if you think about like giving someone a bubble pack of medications, that's not appropriate to give to someone that's living outdoors, because that's going to get wet, then their meds are going to get wet, and then they're not going to have their meds. Things like that. You really have to think of their environment and think of the what our folks need and adjust based on that. Thanks for that question.
Thank you so much, Ashley. Chad, did you have any insights on that one as well?
Excellent question. So this goes back to trauma-informed care. And so what some of our folks, especially with my practice, the folks that I most spend attention on are most initially want nothing to do with me. So folks are kind of hostile and scream at us, and who are maybe paranoid or delusional. Those are the ones that most need our help. And so a traditional assessment would be like a 30-minute interview. But for someone like that, who might swear and scream at you or walk away or threaten you the first time you see them, it's going to take a process of regular engagement and slowly getting to know them, buying them a cup of coffee or something, or give them a cigarette, and then kind of modifying your assessment to not expect to be able to figure out what's going on right away, but needing to kind of tweak your model of a traditional assessment to take into account the reasons why the person may be pushing you away, and also that should show you that your approach should be even more persistent than someone who can readily accept care. And then going forward, you may even need other interventions with that type of person, including adult protective services, or having a capacity evaluation. Some people need legal guardianship. You might need to find some relatives. So it's just kind of a different way of assessing some of the more difficult patients.
I'll add to that too. I think, so from the Street Medicine Institute, and I will put this website in the chat too, we have a resource page that you can access if you're a member of the Street Medicine Institute, that gives, right now we have it for physical health care, but have written, and hopefully we'll soon have on our website, resources for behavioral health care, but they are alternative clinical guidelines for the street. So thinking specifically about the prescriptions we give and their side effects, and kind of the alternatives for what we are very focused on practicing reality-based care that recognizes the reality of where people live. And so just thinking about things like, you know, if we dose a medication 3 times a day or 4 times a day, probably nobody is going to take it. But and just thinking about, like, if we give a medication for blood pressure that makes somebody have to urinate a lot, that is potentially doing harm because people don't have access to bathrooms and could therefore get a sex offender charge for urinating in public. So thinking about things like that, I think particularly for medications, for mental health diagnoses, medications, most of the medications make people sleepy, and thinking about, okay, how can we balance the need for good sleep, but also with the ability to wake up and protect oneself when needed. And so a lot of conversations I have with people around medications are sort of like, okay, do you have a safe place where you sleep, or you trust the people around you, somebody who could protect you if you're sleeping more solidly? I had a conversation with a woman the other day that sometimes she sleeps in a tree in order to be not visible on the street by herself at night. And we talked about not taking her sedating medication at night when she needs to sleep in the tree, versus taking it when she has somebody's couch to sleep on, things like that. So the other thing that I will say too is that in thinking about the difference between the kind of healthcare that people get on the street from a street medicine team, or, you know, in working with street outreach teams, I would put to you that the difference is that the kind of care that we provide people on the street is actually the best kind of care that you can get, and that clinic-based and hospital-based care should look more like street-based care, in the sense of we are very focused on building trust with people. We are very focused on attending to people's social determinants of health that affect, you know, 70 to 80% of their health outcomes anyway. We are very focused on working with a person on what they want to work on rather than what we want to work on, and kind of checking ourselves and our agenda at the door. Not to mention, like, who kind of doesn't love the idea of receiving healthcare in your home when you're sick instead of having to go somewhere for it? So even though we recognize that, like, best care and kind of best practices of care to a certain extent really can't be done on the street, we're not going to do a incision and drainage of an abscess on the street, but the sort of ethos of the way we provide care on the street probably looks better than the ethos of how it's provided elsewhere in the health system.
I wanted to actually add something to that, because Liz got me thinking. So at least in Nashville, if you miss 3 community mental health appointments, you're tagged as like non-compliant. and the like blame is put on you. And so when we're showing up to people's encampments in their homes, like they're getting the care, right? And they're getting seen, and they're not going to like, blame is not going to be put on them for like not showing up to an appointment, right? So I also wanted to add that because I agree, like really in clinic care should really adopt a lot of like what street medicine work is doing for people, because more people are getting the care that they need with this model and not getting like discharged, for non-compliance.
Thanks so much, Ashley. And Liz, I appreciate you jumping on, Ashley, but Liz, I appreciate you framing it in that way. And it actually kind of links to another question that we wanted to ask, which is, we talked about not just the importance of being able to assess folks' behavioral health needs and also begin providing some level of care while they're living unsheltered, but also wanting to kind of set the stage for, make connections for additional follow-up care. And like Liz, you mentioned some specific examples of care that really should be provided, in inpatient, or at least inside, in more traditional settings. But given what you just were kind of framing as the kind of almost like gold standard, at least idea in terms of customized care and like meeting people where they're at, I am curious how that impacts your ability to kind of successfully connect people to more mainstream, ongoing care. Because presumably that shift could be tricky for people when they've had one type of care. And so this question is for all three of you. Maybe we'll start with Chad, just because we just heard from Ashley and Liz. But if you could talk a little bit about just like what those attempts, at least, of connecting folks to more kind of ongoing care look like, and what some of the challenges are to making that be successful.
I guess a fair analogy is thinking about ACT teams, right? Assertive community treatment teams. There's been that lifelong argument of should someone always be an ACT patient, or should they be transitioned to more mainstream case management models when they get better? During my 22-year career, I've found that if provided the best way, and what Liz was talking about is street medicine being providing care the best way possible, what I've found is because there's this mismatch and traditional services don't appreciate some of these values that we hold dear about trauma-informed care and meeting them where they're at. I've often found that once we've tried to transition folks to mainstream models of care, there's a fairly predictable transition point, and if not kind of given a warm handoff, there's often times where the receiving agency either doesn't mimic the care close enough, and the patients feel that they're not being cared for the way they were before, or either that or the intensity of follow-up falls off, and the patient has some decompensation or adverse outcomes related to transitioning back to a traditional model of care.
Thanks, Chad. Ashley or Liz, do either of you want to add anything?
I always
have something to add to it. Go ahead, Liz.
It was mostly a rhetorical question, but I just wanted to at least prompt you.
Thanks, Liz. We've seen that getting people to actually just like trust the system as a whole has been really helpful, because like when they would meet with a street medicine provider in their encampment, and we were able to maybe have them in for three months or 4 months, and then the outreach worker was kind of that like common denominator, and the person that even like introduced the person to the provider, and then we will continue to follow them like when they get into a clinic, I think is like is what we see, because we're the outreach side of it. And I think that that's a big piece of it, is making sure that you have that comfort person that can help connect. But we've really seen that like people are starting, like once they trust the system, and yes, a lot of people, maybe like their history of incarceration or whatever, they have these traumatic histories, and they don't want to be in the four walls, right? And so it's a slow process, but our providers never just like the street medicine providers never just stop saying at 4 months we're done, you know, and we like, so it's just really important that the outreach team like continues to work with the person as they make that transition when they're ready, right? Like it's all about when the member is ready, you know, and for us at least, I mean, there may be time frames on other programs or whatever, but at least for us, like it's when the member is ready to move into more like more of a clinic setting. And it really helps that we have that person, that outreach worker that can help support them into that care. But it's really about trusting the system and trusting like, okay, well, I see that this street medicine doctor is a very like calm energy and like these medications help me feel better. And, you know, and so then they see what it's like in a healthy way. And then that outreach worker is able to get them connected to someone else, you know, in a more traditional setting so that those street providers can start working with other people. So that's kind of our experience.
Yeah, and I'm so glad you went first before me, because the founder of the Street Medicine Institute and our medical director, Dr. Jim Withers, has a name for that process, and what he calls it is trust grafting. So in the same way that you might do a skin graft to graft healthy skin from one area over a wound for an area that doesn't have skin or unhealthy skin, we are grafting trust from one healthy, trusting relationship to another hopefully healthy, trusting relationship. And having somebody from the team who can walk the person into the clinic or the health system, or maybe most importantly the emergency room, and model good care and good interaction with the person sleeping outside is such a vital component of what we all can do. We've seen also sort of the unfortunate hierarchical component of medicine too, in the sense that we have had, for example, our community health worker walk into the emergency room with one of our folks, and then one of the physicians from our team may be able to go in and also kind of be there for some of the time that the person is in the emergency room, or have the function of kind of communicating with the person who will be providing medical care in the emergency room. And we have seen this sort of dose response relationship of like the community health worker or our social worker getting sort of the treatment of the patient improves with their presence in the emergency room at the patient's bedside. And then when you insert one of our physicians into that, the level of kindness and care that the person in the emergency room receives increases even more, which, like I said, is an unfortunate component of the hierarchical nature of our healthcare system. But that having potentially many members of the team be able to walk the person into the system and model how the system should treat our patient is so important. One of the other things that one of my colleagues who is on our street medicine team and helped found the Center for Inclusion Health at my health network said that one of the cool things about our street medicine team is that I said earlier, none of the prescribers on our team work on the street full time. And part of the reason for that is that we not only want to be the people sort of on the outside opening the door into the health system, but we also want to be the person on the inside opening the door and saying hi to the people who are coming in off the street. And so a lot of times, and this is especially true for our patients that we're working with opioid use disorder, we may be doing that outreach or the street rounds on the street, but we are also going to be the people that they see when they come into clinic to get their ongoing treatment. And then as people get more stabilized or end up going elsewhere or whatever, they make more connections with other people in our health system that can continue to provide good care for them. But we're also sitting in those clinics with other providers modeling how care should be provided. We have our internists have resident clinics. So if somebody needs to come inside for primary care, they'll be getting that from one of our internal medicine residents, but it's going to be the street medicine, one of the street medicine doctors who's supervising that care. So if you're not in Disney World like we are, I think at the very least offering that kind of walking somebody in and modeling respect is so important.
I also spent a lot of time, wonderful points, by the way, Liz, when I work at the hospital, and sometimes I bring in some of my homeless folks, and sometimes they have terrible hygiene, lice infested, argumentative, hard to love. In the future, when that person is hopefully doing better, I always try to remind the staff that help take care of that patient in the hospital that this guy is doing so much better now. I wish you could see how wonderful Mr. Smith is doing after 3 months. Thanks for your help. And any of the police officers who had to drag some of my patients into the hospital and didn't find it too pleasurable, I always, if I see those people, I try to give them positive feedback, but how helpful they were to my patient and how well the patient is doing now, and just kind of modeling empathy and respect for these patients to people outside the homeless world.
Thank you so much, Chad, Liz, and Ashley. We are getting close to time, but we had a question that we wanted to ask you about. Someone asked about if you see traumatic brain injury as something that's occurring a lot, but we wanted to make it just a little bit broader. And what are some of the behavioral health needs and conditions that you're seeing emerging a lot in the people that you're serving in unsheltered situations? I see multiple people off their mute. So Liz, you look like you're ready to go.
Sure. Yes, to traumatic brain injury. I think it's very underestimated in the unsheltered population. Absolutely. Worth screening for and asking about head injuries and with or without loss of consciousness. In general, I think there is some sort of locality to the prevalence of different diagnoses that you see people having out on the street. Having done street medicine in both Atlanta and Pittsburgh, I can speak to that. I think particularly when it comes to substance use. So I worked in the downtown area of Atlanta, and that was a location where we were seeing people predominantly with alcohol and cocaine use disorders. If we had chosen to go into a neighborhood of Atlanta called the Bluff, it's like the heroin capital of the Southeast, we probably would have seen more people with opioid use disorder. But since we were largely focused on the downtown area, it was alcohol and crack. And so subsequently, we tended to see a lot of the kind of manifestation of long-term crack and alcohol use being hallucinations and delusions. And I would say, I don't know, this is just my perception, but I feel like downtown centers tend to attract people with psychotic disorders like schizophrenia and schizoaffective disorder. That's just my own perception of what I saw in downtown Atlanta and downtown Pittsburgh. In Pittsburgh, however, the predominant substance of choice for most people is heroin, which is in Pittsburgh actually almost solely fentanyl. And there's fentanyl in everything. There's fentanyl in the cocaine, there's fentanyl in the marijuana, there's fentanyl in the pressed benzo pills that people can get. There's fentanyl in the ecstasy, like it's everywhere. And so I would say that even though trauma and PTSD were highly prevalent in both Atlanta and Pittsburgh, I think that I see even more people with PTSD in the Pittsburgh area, both sort of part of the reason that people are using opioids, but also from losing friends, having to revive people in overdose, both successfully and unsuccessfully, being a part of the, not a small part of the contribution to the development of PTSD as well.
So much, Liz. Chad, Ashley, any insights into what you've seen?
Yes, so along that point of trauma, PTSD, trauma-informed care, I just wanted to emphasize the fact that for the chronically homeless population, it's safe to assume that most people have been through lifetime trauma. On top of that, just important to keep in mind that of the female patients who are chronically homeless, it's almost universal that any female having to live unsheltered for more than a short amount of time would be subject to sexual trauma, and so it always is going to kind of color the way the interaction goes, and you have to be extremely mindful of the sexual trauma in any kind of assessment and interventions provided to that person.
Thank you so much, Chad. And Ashley, any thoughts on this one?
I mean, since we're not the ones like diagnosing and stuff, I mean, but we do see a lot of trauma. We see a lot of assault. So pretty much like a very large percentage of the folks that we serve, when you ask if they've had a brain injury, it's a yes, you know, because of assaults. And I mean, assaults on the streets happen daily and sometimes multiple times a day. You know, we've have been taken into emergency rooms, released from the emergency department, and then assaulted again. They live outdoors, so they are right there, you know, they are a target, and it's awful what people experiencing homelessness go through. So I just wanted to add that a very large portion of the folks that we see have a TBI, whether it's been diagnosed or not. You know, that's the other thing. Sometimes they don't even go to the hospital. You know, they have no way to the hospital. They have no way to call an ambulance, right? So often people are just recovering in their tent, hoping they didn't have a concussion. So we see that a lot, yes.
Yeah, I will also just, I know we're out of time, but just add to that, I think that what's really unfortunate about some of the treatments for the mental health sequela of traumatic brain injury are not medications that I would recommend people to take on the street, either because they require blood levels to monitor toxicity, or have potential serious consequences if you don't take the medication every day. So not medications I really like to prescribe on the street either, which is unfortunate.
Thank you to this incredible panel. We could probably talk to you for another 2 hours. So hand it over to Jillian to wrap us up.
Hi, thanks, Alicia. I was actually just going to say the same thing. I wish we had scheduled this for like a 6-hour webinar series. I'm sure people don't want to actually sit in front of their computer screens, but I bet if it was you all talking, they'd be okay with it. So really, really appreciate you three. I know there were so many questions we didn't get to, so apologies for everyone whose questions we didn't get to. We really appreciate how engaged everyone has been and how many questions you did submit. And I really encourage you all to look into our fabulous panelists, like organizations that they're working for, and the Street Medicine Institute, for example, for more resources, and to follow up in your own communities with, if you're on the homelessness side, with healthcare providers and vice versa. And again, really encourage you all to go back through the if you haven't watched sessions 1 through 3 of this series, really encourage you all to go back and look at those recordings and slides and resources, because they are meant to be kind of a package that builds from each other. So again, thank you so much, Ashley and Chad and Liz. Really, really appreciate you sharing your expertise and taking the time for this. And I will pass it over to Jen to wrap this up. Thanks again, y'all.
Great, thanks. And just from HHRC, we are just so thankful for your time and expertise today. I also agree. I wanted just to keep listening to everybody. So we'll bring everybody back next year. We'll have to keep thinking of ways to work together. And we've heard from all the attendees, you want more of this type of training. So stay tuned. We've got some plans in the works to keep offering trauma-informed training. There's an evaluation link and a certificate of participation. Doesn't work for you the first time, give it a few minutes. That website's a little particular, but huge thanks to Alicia and Jillian from Homebase. We have just, they are responsible for putting all of this together and facilitating it. And it's just been a real pleasure to partner together on this training series. So just, we've enjoyed working with Homebase and the team, and we look forward to working together again. And thank you to all the attendees. 4 sessions of an hour and a half is a lot. We know that you have a lot on your plates and a lot of your time. And so we just want you to know that we really value you. And so that's why we are here doing this work. So until next time, thanks everybody and have a great day. Take care.